with as internal medicine doctors. And so let me give you a little bit of HPI. A 24-year-old woman presents with 1 day of speech changes. She was in her usual state of health until today, when in the setting of being upset that her partner was in jail, she drank a pint of hard liquor and subsequently developed speech difficulties that she felt were disproportionate to her alcohol use. Specifically, she reports trouble with word finding and finishing sentences and thoughts coherently. She denies new extremity weakness or numbness, new vision changes, headache, neck pain or stiffness or fever, and she declines to answer further review of systems questions. Her case manager called EMS earlier today when the patient was noted to be, quote, belligerent and slurring her words. The patient wanted to leave from the ED, but was determined not to have capacity to do so.
All right, Jason, with that, I'm actually going to share our whiteboard screen, and me and Eric are going to defer to our other co-chiefs to kick this one off.
That's a good deflection, Dr. Gergen and Dr. Rudolpher. So I could start off real quick. So I guess so you're saying she has difficulty not getting words out, but just kind of with word finding itself?
Yes.
It's like right there.
And getting the words out too.
Because then, obviously kind of thinking about aphasias, you got to think about a Broca's aphasia and Wernicke's aphasia, especially in somebody who's having an acute stroke. And Wernicke's is they have difficulty kind of figuring out the words, and they kind of have the word salad. And then Broca's aphasia is classically, they have difficulty kind of getting words out, and they're always at the tip of the tongue. And a 24-year-old having a stroke is highly unlikely unless she's got APLS would be the only thing I could think of. So especially in the context of her drinking the alcohol, do we know what type of alcohol she drank? I know it's just a pint of hard liquor, but was this something that she bought at a store? Was it her buddy made it in his bathtub?
It's a very Southern thought, Corey. No, it was from a store.
Okay.
Yeah, Amelia and I agree. We think that the acuity of the situation certainly puts this as a central nervous system and mostly localizing to the cranium problem. And then to think about what occurs this acutely, I feel like meningitis usually comes on more slowly, but something like HSV can affect areas in the temporal lobe. Other things to think about are stroke, so we'll have to do a better neuro exam, but certainly she already has a speech problem, so we're gonna be going to imaging quickly here. And then things to think about are press, which can cause these type of neuro changes and can occur in anybody. So these are the things I'm thinking about.
I would say the other thing that I would add is just, even though she's reporting this acute change, making sure we get some collateral information that supports that this has been an acute rather than acute on chronic or subacute process, because that could change our differential a bit.
Yeah, I'm right there with you guys. In the acute setting, a rapid infection, obviously there's certain things that could, but I would think intoxication or vascular would be the two things I would, or toxin induced versus vascular would be the top of mind differential right now, especially in the context of her history. Dr. Gergen, Dr. Rudolpher, do you guys have any thoughts?
Yeah, I guess, I kind of want to know more background. Why does this 24-year-old have a case manager, right? So is this a long history of severe substance abuse that could cause some chronic neuro changes? Is this a patient that maybe had TBI and seizure disorder or developmental delay that would also make her susceptible to other cognitive deficits or other neurocognitive disorders?
And then what's the rest of her psychiatric history is another question beyond that.
Yeah, I completely agree. I think the thing I like you guys all did was basically, I think while it may localize to the CNS right now, I think notably this HPI, for me, isn't super helpful because I don't think it really narrows it down a lot. And so I think we're all still keeping this thing broad. I liked Corey's thought about APLS. So is this another organ system that's then secondarily involving the CNS? But unless you guys have additional questions, I think I would like more knowledge and more history about this.
Well, I'm happy to provide that. Let me just pull up the sheet. So for our second aliquot of information, we have the patient's past medical history, which is significant for a congenital left six nerve palsy, as well as reported protein CNS deficiency, but this is not, corroborated in the chart, at least with what we have available. She's had 3 prior strokes, most recently 4 years ago, and she has residual mild left arm and leg weakness and numbness. And then she also has this weird history of anasarca of unclear etiology that has improved in the past with a high protein diet. She also has a chronic kind of intermittent non-bloody diarrhea. And then with regards to her family history, her father had 8 strokes in his lifetime prior to his death at age 54. With regards to her social history, she's a former smoker, recently quit, of only about 5 cigarettes per day. She sporadically binge drinks, much like immediately prior to this presentation, but does not use alcohol on a daily basis. She uses marijuana on a daily basis, does not use any other illicit substances. And then she's sexually monogamous with 1 female partner. As far as her medications, so she takes a full 325 milligram aspirin every day. She uses atorvastatin 40 milligrams daily, bumetanide 1 milligram twice a day, intermittently uses loperamide for the diarrhea, and then is also on ranitidine 150 milligrams twice a day.
Cool. So I think Sneha and I were talking, and the first thing that jumps out about this now is we're thinking more about like a congenital process or some kind of a genetic process going on, given her significant prior history as well as family history of strokes, thinking about any kind of things that cause vascular malformations, as well as changes in the clotting cascade.
And then, just for everyone that's logged on, like obviously we're going down this rabbit hole of common/rare conditions, but also taking a step back and thinking about like sick versus not sick. This patient is in the sick category, and it sounds like these changes have been going on for a day, but some newer recommendations when it comes to stroke interventions have broadened the timing with which you can intervene. So certainly, like, I am quickly looking to what her vitals are, what her pressure is, etc., and thinking about interventions, but I'll stop there.
I think to broaden this a little bit and maybe get a little bit away from the CNS, we know that, patients that have baseline kind of sick brains can have mental status changes to pretty much anything. So I kind of I'm like interested, is there like a metabolic insult going on, some sort of other toxin ingestion, infection, kind of your delirium workup almost that might be triggering the presenting symptom?
Yeah, and kind of just going back in her past medical history, the thing that kind of sticks out to me is so if somebody who's got edema and diarrhea, and really of unknown etiology, which means it's probably been extensively worked up. But the things I kind of think about with that is like a protein losing enteropathy, and trying to kind of connect all those would be kind of something that's a little bit tough for me to, in the context of her CNS symptoms as well. But just kind of thinking about odd things and trying to piece things together. And also just the family history of strokes, kind of piggybacking off what like Sneha and Amelia were talking about with congenital things, thinking about maybe she's got homocysteine deficiency is one of those that people can be hypervascular, and it can be like a family history of strokes. So just one of the things to kind of keep in the back burner.
Corey, I don't give you enough credit sometimes for dropping the knowledge bombs. That was awesome. Yeah, I think I completely agree with everything. I think like, especially like Amelia said with the clotting cascade and with Corey, like maybe invoking a protein losing enteropathy, like people with nephrotic syndrome, like spill albumin and they spill their clotting factors into their urine and then become more hypercoagulable after that. And so I think, at least for me in this one, I think the part of this that helps narrow it down is actually the edema. I think that workup becomes like a little bit more specific necessarily than like, broader causes of diarrhea, this questionable history of CNS deficiency. Like we know she has edema, we can see it on exam, hopefully, and then kind of further working up that. I'll toss it back to my co-chiefs here. Does anyone have a system for how they think about edema?
I think that's a challenging one, Danny. I think in general, kind of a systems-based approach, thinking about if we think it, yeah, perfect. Is it, the first systems I'm gonna go to are cardiac and then renal and hepatic or liver. Thinking about like cardiac, is there not enough flow and that's what's leading to it? Hepatic, are we not making enough and that's what's causing it? And renal, are we not filtering it appropriate? Are we losing it?
Yeah.
And Amelia means production of proteins, albumin more specifically.
And yeah, the only other thing I would add, just like that's even broader, is just even going to like what we learned in medical school. I wish I could remember the formula or remember what the formula was called, but just thinking about blood vessels and how we actually keep fluid in, hydrostatic and oncotic pressure. There's elevated hydrostatic and low oncotic pressure.
Can I jump in here for a second?
Yeah, go ahead.
Yeah, help us.
So what you're talking about is the Starling equation. And the Starling equation has several variables in it. The first is vascular permeability, KF. The second is hydrostatic pressure, both inside the vessel and outside the vessel. And then there's sigma, which is the vascular permeability to protein, and the intravascular and extravascular osmotic or oncotic pressure. And the key reason I wanted to jump in here is that even in the setting of nephrotic syndrome or other chronic low protein, low albumin conditions, the body's response is to retain fluid, and the interstitial protein drops as much as the intravascular protein. So the transvascular gradient for protein is unchanged, and it's not the low intravascular oncotic pressure that allows edema to form coming out of the vessel. Rather, there's fluid overload because of retention, and it's still a hydrostatic problem. So unless the albumin is really low, like point something, you're dealing with a high pressure scenario, intravascular hydrostatic pressure going up. Although that is the normal response to an intravascular protein deficiency. Okay.
Awesome. Thank you, Dr. Albert. For our applicants who are on the call, Dr. Albert is one of our expert clinicians here. He's a professor in the pulmonary and critical care department. And he, if he says a diagnosis in conference, typically it's the right diagnosis. So we are eyes on the chat at all times. All right.
I'm refraining because I don't want to give the Chiefs any help.
Fair enough. Co-chiefs, you guys ready for next piece of information?
Yes.
Right, it's kind of freaking me out that you guys are already interpreting the labs when we haven't even got to the physical exam yet. But about that physical exam. So vitals are essentially normal. You can take a look at them right here. She was alert and oriented. So her HENT exam was notable for periorbital edema. She had an unremarkable pulmonary, cardiac, and abdominal exam. And then her skin was warm and dry without any rash or jaundice. Her extremities, sure enough, did have 2 to 3 plus pitting edema to the bilateral hips. And then her neurological exam, a lot of what we were capturing is chronic stuff, but she did have, and this was elicited with the help of our neurology colleagues, a moderate expressive aphasia, along with her chronic left 6 nerve palsy, along with her chronic left upper extremity 4 plus out of 5 strength, and along with her chronic left upper extremity, left lower extremity diminished sensation to pinprick. Her reflexes and coordination were normal, and then her mood was depressed. Her affect was tearful.
Did she have arm edema as well and facial edema?
Well, she had the periorbital edema. The arm edema, it may or may not have been there, but it was not noted either way in the physical.
So that's a further support for what I was talking about. If the edema is due to low intravascular protein, it should be total body. If it's only in the lower extremity, it's because the venous pressure is higher in the lower extremity, leading to transvascular fluid flux.
Yeah, I think one of the things I like totally forgot to mention too, like thinking about like six nerve palsies is like, if I'm not mistaken, it's kind of like a frequent palsy of the facial nerves. And like, just, I think one of the things we didn't even think about is like thinking about like metabolic etiologies for these kind of cranial nerve palsies, including like diabetes, but also like, I know there's nutritional deficiencies, but just aren't coming to me right now, but just another thing to be thinking about as well.
Don't forget the thyroid, it can do everything.
Well, Jason, I'll say that, you know, what was reassuring to me on the exam was the pressure, but otherwise it didn't help or hurt me that much. I think we were expecting this exam. And so we were just sort of trying to tie in like what causes both low oncotic pressure plus these stroke-like conditions. And so something that I thought about was like lupus GN plus APLS, because patients with lupus can often have APLS in conjunction. But again, now, like Eric and Danny pointed out much earlier, we're thinking more of a systemic disease that's causing these CNS findings.
Yeah, the other thing that I will add is like a nephrotic syndrome, which has some hypercoagulability associated with it, depending on the etiology. I think some etiologies of nephrotic syndrome are more strongly associated with loss of antithrombin 3 and hypercoagulability.
That's exactly right.
Are we ready for the next set of information?
The next set of information, Jason, where are you going to next? Should we talk about what we would want to get? Are you doing labs? What is the next?
I'm gonna do some labs.
So maybe we can.
Yeah, let's talk about what we want and why.
Yeah,
that's a great idea.
The first set of labs, I should say. Nothing too exotic.
Yeah, and I just want to point out Dr. Chan's teaching point in the chat. So Ed Chan, another one of our expert clinicians, he's a professor at the VA in the Pulmonary and Critical Care Department who comes to a bunch of our conferences. And again, anything he says, like Dr. Albert, got to trust implicitly. Making the point that periorbital edema is more consistent with nephrotic syndrome than other cases. And I think we had a good case earlier in the year that I think one of our future chiefs, Cassandra, presented, where she looked at someone's photo ID and basically saw that they had more periorbital edema compared to prior. So just a good thing to keep in mind when you're running through your HPI. And then I think also, I would also keep Corey's thought about protein losing enteropathy on here, because I think that's one way to tie together the diarrhea. But yeah, a lot of this doesn't sound cardiac to me. I agree with you guys. This sounds like something diaphragm and below.
What else do you guys want right off the bat for labs and why? I mean, UA I'm going to see for protein, blood loss, CMP obviously for metabolic, and then seeing what the protein state is in the liver, and then CBC you normally get for most patients. See if their platelets are low, anemia, pancytopenia, that kind of thing that might support something.
No, I agree with you, Sneha. I mean, this is what I would start out with.
Yeah.
So.
I threw in TSH just so I can get that off my differential.
The ED would get a pregnancy test because she's young.
Yeah, and I think, I mean, Yeah, actually, I agree. I think I would start there. I'm not sure I would get much else right off the bat. I always hesitate like getting an ESR CRP in these people to help like quantify maybe how long they've been inflamed for. But based on her history, I think we already know the answer to that. And so I don't think that's going to actually give us useful diagnostic information here.
Yeah, and I think it's tough, especially with those inflammatory markers, that if you don't have much, if you have prior ones, they can be really helpful. But if you don't necessarily know what's going on.
All right, I can give you all of that, including the lipids, Dr. Albert. So, oops. All right, so here's the first set of labs for you. So I'm not going to slowly read all these numbers to you, but I'll just point out some things. So CBC basically had a normal white count, a normal hemoglobin, but with an elevated MCV of 106 and borderline low platelets at 147. BMP was pretty unremarkable. K was borderline low. Calcium was low at 6.8, at least before correction. And then moving right along to the LFTs, so our total protein was very low at 3.7, albumin 1.6, with a total billy that was normal, along with normal transaminases and alk phos. UA only showed 1+ ketones and few squamous epithelial cells, and they actually sent a separate urine protein, which did not show any detectable protein. Normal INR, normal lipids, normal A1C, normal TSH, normal B12, normal folate. Iron studies just showed low TIBC, but otherwise normal. Vitamin D was borderline low. And then alcohol was interestingly negative. Urine drug screen was negative. Urine pregnancy test was negative. And then the fastest returning SPEP of all time came back with hypoalbuminemia and hypogammaglobulinemia.
So I think, can people hear me? Sorry. I'm here with the rest of the Denver Health crew, but so looking at this, I think I'm most noticeable. When I think of anything that decreases protein like across the board, I think of like malnutrition states, so she like chronically malnourished, but for how long this has been going on, seems less likely. I don't know that I can't think of any like congenital protein synthesis deficiencies that would be going on for this long. And then I think about, is she losing protein somewhere? And that's why I was surprised to see her UA come back without protein. That's, we've been talking a lot about nephrotic syndrome, so I'm thinking where else could she be losing protein?
Yeah, Ben, I completely agree. I think the thing that me and Eric both kind of gasped about under our masks here was that UA came back with no protein, and especially the urine protein by itself was undetectable. I think that's like been the first time in this case where we had this like schema in our heads that we were tracking, and it just completely went the wrong direction. And so going back to that like whole cause of edema earlier, me and Eric were talking about is like, based on this, it seems like the kidneys here probably aren't the reason why this person is edematous. And so at least from these labs, we've knocked off one of those organ systems.
I do think it'd be helpful common things and going back and doing like a good nutrition history for someone who has an extensive potential psych history. So I'd like to know kind of a little bit more about her diet. Just thinking of common things.
Yeah, and even just a kind of, she has like a borderline low vitamin D. Usually, I mean, if these people are like, who don't absorb, like similar with celiac disease, you don't absorb soluble vitamins. Usually, like they're have like no vitamin D. But like I would, just even check it as like a kind of an objective test for nutritional status. I think getting an INR would be checking like vitamin K levels too, and also be checking synthetic function for her liver. So kind of another thing to rule out for etiology for hypoalbuminemia.
Yeah, so what's our differential for hypoalbuminemia? This is not one that I toss around a whole bunch.
Yeah, we don't hear either. To take a step back and think about the whys and like more to pathophysiology when you don't know how to work something up it's either it's a production problem, loss, or
Or like
loss
what she's
slash
making, does it
malabsorption.
work? Yeah.
And if we're not seeing it in the urine, she may be losing it another way. Like we're saying that she may have a protein losing enteropathy. Corey, I don't know if you have any ways to look for that or what you were thinking.
Danny,
I'm also,
yeah, go ahead. Amelia, sorry.
oh no, I was just gonna say, I'm really interested in like the nutrition question that Ben brought up. I think we know albumin and pre-albumin aren't always the best measure of nutrition, but the low vitamin D and then an elevated MCV to me is always like a poor man's test that there's likely some kind of deficiency. She's not getting enough product to make healthy blood cells.
Seems that those levels are just not far enough off to me. Like they're close enough to being normal. I don't know. And Jason says she's on the standard American diet. I feel like production might be where I'm headed.
Yeah.
Corey, what were you gonna say?
No. I was just gonna say, yeah, and this is one I'd probably probably do like a thorough evaluation, like to see how they worked up this edema. But I agree with you guys. Like, if you want to, I've talked with Danny about it because he knows I think this is the best test of all time to order because it's just such a horrible. I feel like it'd be just horrible for anybody to have to do it. But yeah, a 24-hour alpha-1 antitrypsin stool collection is the test to rule out protein lose or to check for protein losing neuropathy. I think in the same vein, like she's a 24-year-old female. Like, Jason, what? So I guess like the other thing to think about is like celiac disease, which is going to be picked up on a 24-hour alpha-1 antitrypsin. I am kind of like, I do wonder if this is like with these nervous symptoms, if there is some kind of metabolic component, like some kind of deficiency, like that I'm just not thinking about. But yeah.
Or do you mean more like zinc, copper, like some of those micronutrient stuff? Because obviously we're not seeing any major ones here other than the protein.
Yeah. Something I don't know if like, isn't there? I mean, like, I don't know if like manganese or like micronutrients. Like you're getting like deep into the micronutrient hole. If we
Hey, Corey, if this is manganese, I'm shutting this computer and walking away. No, I like that thought though. The thing that Eric and I were thinking is like, Whipple's disease. I've never seen it, but I guess like theoretically this kind of vague systemic symptoms of protein loss. And then I also like giardia. I mean, I think like, chronic GI infections that are going to cause you to have similar symptoms. I throw those on there. But I think we all narrowed in, it sounds like, on either production problem or loss via the bowels. Is that correct?
Yeah, and Jason, is there like more history about her diarrhea? Because we didn't really get much of a diarrhea history in the HPI.
So we're making it as authentic as it was in real life. Like we just know that she's had intermittent, non-bloody, kind of watery diarrhea. And that's all that the admitting team was working with. I think now may be a good time, if no one objects, for me to we have a very brief aliquot with just imaging that maybe I can share with you guys. So the inpatient team did get a bilateral lower extremity ultrasound, didn't show any DVT. She did have an echo, which showed moderate aortic regurgitation, but otherwise was quite normal. And then she did have an MRI brain, which showed an acute infarct of the left frontal lobe and anterior aspect of the left insular cortex, along with focal encephalomalacia in the left parietal lobe, which was thought to be sequelae of old ischemic injury, as well as mild white matter changes, also thought to be sequelae of chronic microvascular ischemia. Next aliquot has a lot of tests, some of which you guys were already talking about, so I don't want to belabor the point, but I was just curious on any thoughts of what you guys might want next.
Yeah, the one thing I guess I was thinking about, a young woman with aortic regurg. We didn't go into depth about her sexual history, but somebody with CNS symptoms, even though it looks like they're from an acute stroke, I definitely would probably want to, with aortic regurg, I would definitely want to check for syphilis. Would be something to make sure about that. And then a young person who's got a young person with acute ischemic stroke, like evidence, 100% would check for APLS labs without a doubt, especially where there's thrombocytopenia.
Jason, was her EF normal on that echo?
Yes, her EF was like 70, 75.
Yeah, so the aortic regurg is kind of a weird finding. I'm not really letting it change my thinking too much here, because we don't really see any of the evidence of it. Like, it hasn't burnt out her LV. She had a normal EF. Her pulse pressure wasn't that wide. Like with bad AR, you'll see a really wide pulse pressure, like 120 over 35 or something. And so it kind of makes me wonder if this is just incidental or maybe syndromic from something. It's not really changing the way I'm thinking about this case.
Yeah, I agree. That imaging didn't really, me and Eric were talking about the aortic regurg, but that imaging didn't really push me one way or the other. And I think the stuff that Corey, Sneha, and Amelia have already brought up in terms of labs and next steps is kind of where we're all heading. So what else? So I think Corey, you said you wanted to get that 24-hour stool test, and Dr. Chan agreed, which means it's definitely the right thing to do. What else do we want to grab? Me and Eric are going to, we're going to send that GI PCR as well.
I mean, I would grab APLS labs too, just in the context of her having an acute ischemic stroke in a young person.
All right. Check cholesterol. So cholesterol was already checked and was normal. Fibrinogen and ceruloplasmin.
That's interesting.
Well, those are really good ideas. Let me share what we had. All right, so a lot of information coming at you. So your sub-I, who is interestingly a future CU internal medicine resident, went through the chart and found a pretty extensive workup from 4 months prior. And so just running through it, HIV negative, viral hepatitis serology is negative, ANA negative, antiphospholipid syndrome panel negative, antithrombin activity normal, prothrombin mutation normal, factor V Leiden normal, protein C activity normal, protein S activity normal, with the understanding that all those prothrombotic labs can actually be normal in the setting of an acute clot. So, and then tissue transglutaminase antibody negative, homocysteine level was normal. Her serum alpha-1 antitrypsin was just this side of normal, so a little elevated, but certainly not deficient. And then she had low copper levels at 46, low zinc levels at 43. Moving on to the stool studies, so fecal fat was normal, fecal calprotectin was normal, stool pancreatic elastase was normal. The never unhelpful fecal occult blood test was negative. Stool PCR was negative. Stool ovarian parasites negative. And then the stool alpha-1 antitrypsin was undetectably high. She did have an EGD, which just showed a 2-centimeter hiatal hernia with a normal esophagus, stomach, duodenum, and from what they could see of the jejunum. And then a colonoscopy demonstrated a normal colon. The next aliquot will reveal the diagnosis.
Corey, you've pulled this train this far. Why don't you go ahead and take the first stab at that set of results?
Yeah, I was hoping you guys. I was going to let somebody else talk first because I know how to check for protein losing enteropathy. I don't know what to do after I find the protein losing enteropathy. So I guess like looking at, so she had an EGD that didn't. I didn't see any path results from that, or maybe I didn't read close enough. I don't know if they biopsied to see if she had celiac disease, but her TTG was negative. And she's also micronutrient deficient in copper and zinc with a normal diet, so she's not absorbing her food. So yeah, this is kind of pushing me. I would probably, Jason, did they do biopsies and his path back on her?
They did do biopsies, and it showed normal GI mucosa.
Okay. So it makes me think she's got, man, this is tough. I'm trying to think about what like protein losing enteropathy in combination with a micronutrient deficiency. I'm a little bit stuck right now. I don't know if anybody else has any ideas.
Corey, that was amazing. I think the one thing me and Eric were thinking of is like, where have we not sampled yet? Like if tissue is the issue. So we have colonoscopy, which is normal. We have EGD, which is normal. And so depending on whether or not the person's had like a push enteroscopy or something, we're missing a segment of, jejunum and ileum, probably where there could be pathology. I admittedly do not know enough about alpha-1 antitrypsin and protein losing enteropathies to know where the site of that is, but me and Eric were just wondering if we should say next step is try to biopsy the last part of the bowel that we haven't touched yet.
Yeah, Sneha, I would have called GI. I don't have a good framework for what to do next.
What do we think the piece of evidence that's going to clinch this is going to be? Like if we were taking bets. So I think it sounds like all of us are saying that this is a protein losing enteropathy, correct? We've bought Corey's theory.
Yeah.
Yeah.
So what is the thing that's going to clinch this diagnosis?
Actually, I'm trying to think about it. Would Whipple's disease present with, and would you have a normal biopsy with that?
No, I think you should have the PAS positive macrophages, and that's the buzzword I remember. That just I'm going to have till I'm old.
Wait, what have we biopsied so far?
We haven't.
Oh,
We've got the EGD and the colonoscopy. So I think we're missing the jejunum, ileum.
Small bowel.
yeah.
Yeah.
Small bowel, yeah. Yeah, we think it's gonna be tissue from small bowel, obviously.
The only thing I think
Classically, Whipple should have abdominal pain and arthralgias. It also, I think, tends to lose more fat, like fats and carbohydrates, rather than protein. I mean, but you probably could lose other stuff, but I don't know enough about that disease to know any more beyond what I just said. I also don't remember where you biopsy. I know it's a biopsy-proven diagnosis, but I don't know where you get the tissue from.
Hey, Jason, one other question before we go on to the tissue we're going to get, I think, is do we know more about the dad who had 8 strokes? Because there's several causes of what could be what's probably a small intestinal disease here. There are very few causes of a congenital disorder. Is there anything we know more about the dad?
No, that was actually like a mystery. He had all these strokes. He died at a young age, and it was never known why this happened. I think there was a theory that protein C/S deficiency could have contributed, but that was very hand wavy.
Mm-hmm. Because I mean, there's a chance he has what she has, and that's what cost him his life. And again, a shorter list of the things that are handed down than the things that 2 people can get. Not that I know that entire list.
The only thing I was thinking about, like, you wouldn't be able to pick up on a biopsy is if there was like some channel deficiency, something like that. And she's young enough that she could have some kind of congenital like transporter deficiency that we're just like learning med school for step 1 that we have no idea what it is now because we never see it. But
I think we all learned today that Corey has an untapped bank of knowledge regarding protein losing enteropathies and stool testing.
hey, that's where you asked me how to work up diarrhea. I got that down pat.
I cannot believe we had that conversation before. All right, so team, are we thinking asking GI for a push enteroscopy? Corey, you in agreement? All right, Jason, are we right, wrong?
Let's take this home. So GI was definitely involved in this case. So I'm going to switch over to another Microsoft platform.
Jason, can you tell us for learning, at what point did GI become involved in this case?
They were involved during this patient's prior hospitalization, and then they were involved early on in this hospitalization as well. So I'm giving this case a new punny title, a stroke of bad lymphatics, because the next test that was performed was a video capsule endoscopy. And can you guys see the whole screen right now? Okay, great. So the video capsule endoscopy showed diffuse and dense lymphangiectasia throughout the entire jejunum, as well as patchier lymphangiectasia throughout the entire ileum. And you may be asking yourself, what does that look like? And it looks like this. This was an actual image from this actual patient's video capsule endoscopy. Those are dilated lymph vessels basically throughout the majority of her small bowel. So this basically, without a secondary cause, this confirmed the diagnosis of something called primary intestinal lymphangiectasia. And you may ask, what is that? It is a rare clinical entity characterized by diffuse or localized ectasia of enteric lymphatics that is an uncommon cause of protein losing enteropathy. Most cases are sporadic, but it's occasionally associated with multi-systemic genetic syndromes. What happens to these patients? What do they look like? They have peripheral edema. They have pleural and pericardial effusions and ascites. They can have diarrhea and steatorrhea, abdominal pain, bloating, and flatulence. Thrombotic events are very rarely described, most commonly associated with the Chapley syndrome. So that's complement hyperactivation, angiopathy, and protein losing enteropathy, which is maybe what this patient has. We don't know that yet. And so how do you diagnose protein losing enteropathy? It's basically suspected in patients with edema and hypoalbuminemia in whom there is no other apparent cause of protein loss. So like proteinuria in the setting of nephrotic syndrome, inadequate synthesis as in liver disease, or in supply as in protein malnutrition. Its diagnosis is established by an increased clearance of alpha-1 antitrypsin in the stool, as people figured out very early on. And here's the formula for that in case you're wondering. I calculated hers because the upper limit of the test was so low. It was hard to clearly demonstrate, but her stool alpha-1 antitrypsin was undetectably high, so we kind of suspected it. And then what do you do about it? So for all the nutrition-minded people in the crowd, the mainstay of treatment is actually a low-fat, high-protein diet along with medium-chain triglyceride supplementation, because these triglycerides are thought to bypass the enteric lymphatics and thus decrease flow through them. You may also require supplementation of fat-soluble vitamins, vitamin B12, folate, and iron. I think that's just because those dilated lymphatics, you just have trouble absorbing a lot of the things that are generally absorbed in the small intestine. If you are lucky enough to have very localized disease, sometimes they can do surgical resection, but this patient's disease was far too diffuse to even consider that. And then some other therapies that have been trialed like a couple times in a couple people are octreotide tranexamic acid and eculizumab. And so with that, I just wanted to thank the Chiefs for not being stumped, for cracking this case, and for being awesome as always.
I will, did any of my co-chiefs know the actual name of this disease? I had never heard of it.
I've never heard of that.
Okay, so none of us had ever heard of it, it sounds like. Okay.
Yeah,
You know-
this is a new one for me and Eric to add to our differential is primary intestinal lymphangiectasia.
That's usually at the top of my differential and diarrhea workup, if I'm going to be honest. But
So the reason you all should come to Colorado is Corey one morning went on a tangent about alpha-1 antitrypsin in the stool, and I called him crazy. And sure enough, he was right. Like 5 months later.
You saved us all.
So you have.
I didn't even know that was a test you could or should do. Like, this is great.
Yeah, the
And
best part
Jason,
about
can I ask?
the best part about
Jason,
this
I was just
program. Sorry, I was gonna say the best part about this program is all of your colleagues are infinitely smarter than you are, and it is it's a fun place to learn.
yeah, I was kind of interested. You know, the thing that like the weird part to me about this is I don't know if GI commented on it, but why her fecal fat was not elevated if she had like poor absorption from her like lymphatic dilation. Like I thought her fecal fat would have been high too, and that was one that I'm a little bit perplexed by because that's absorbed by your it was brought in by your lymphatic system.
They didn't comment either way on that, and at least in the cursory review of protein losing enteropathy that I did on the internet last night, it's not brought up as like a common sign. I guess they talk a lot more about the increased clearance of alpha-1 antitrypsin.
I want to hear the answer to the alpha-1 question from Dr. Albert, but I will say the only thing I've seen in people who have steatorrhea and fat losing issues with their gut is they will automatically reduce themselves to a low-fat diet because every time they eat fatty meals, they feel terrible, and so they have this sort of natural progression to a non-fat or low-fat diet. And maybe it's that she was barely eating fats when she came in, is my suspicion. But now I want to know why. I think Dr. Albert's going to tell us about alpha-1 antitrypsin in the stool.
Bigger molecular weight.
Oh, I like that.
Wait,
Yeah, I
Dr.
think-
Albert, can you explain that? I don't think I put the P.
No.
Okay.
No, that's the extent of my GI knowledge.
Okay, well, we'll read about it. I'll read about it.
But the comment I made above is important here. There's 3 categories of diagnoses: horses, zebras, and unicorns, and this is a unicorn.
Totally agree.
Nothing but
Remember,
Archie.
I was gonna say, remember applicants, even though this one was a unicorn, we also teach all the other things.
Yeah, Jason, thank you so much for putting this case on. I had a blast. I think we all had a blast. And applicants, thank you all so much for tuning in. We hope to see you guys in person in, at this point, like 5 or 6 months. And as always, feel free to reach out to us with any questions, comments. We know this has been a weird interview year, but we just want to be there to answer any questions we can. Thanks, guys.
So were we stumped?
I don't think so. I don't think I can call that a stump.
Like none of us said primary intestinal lymphangiectasia though.
Yeah, I didn't know those words went together.
Yeah, I'm not sure. But it seems like we were close.
I was stumped. Raise your hand if you were stumped.